Hmm?
We was supervised while we was doing it.
Really?
We was supervised?
Apparently, he was standing right there by the door.
Probably he was very cautious that, was standing by the door just in case he has to run.
Exactly. That's
Never know.
exactly what it was given.
Okay, so this is a tourniquet. What is the purpose of this tourniquet?
To stop.
Make the veins visible. To engorge the veins. So, questions for your exam is to make the veins larger, visible. The tourniquet. That is the major purpose. Now, the second question, because I saw in a video. For how long do you keep this tourniquet?
1 minute.
Correct. Now, there are two ways of applying the tourniquet. Or let's rephrase. Sometimes we have to apply the tourniquet more than once. Right? Yes, no, maybe, probably, could be. I'm lost. What?
I say, yeah.
Me
You
too.
can't keep it on more than like 1
Okay,
minute.
so this tourniquet, sometimes you can apply it only once, sometimes you can apply it twice. When do you apply once?
To check the vein, to see when the veins are like open, like visible. You don't need the tourniquet to see.
Correct. Excellent. If you see my veins, what are you applying the tourniquet to find them? Remember, the tourniquet is to find a vein. But if you already see it and you feel comfortable with it, don't
come up to me with no tourniquet, she's not doing my love.
Hmm?
I don't care if you can see my vein or not. You better follow the steps. I can't. No tourniquet?
You guys not following. I said sometimes you use the tourniquet once or more than once.
I heard you.
So I haven't got to the point, but we're gonna put the tourniquet with you. Don't worry.
Yes, please. Thank you.
Every single patient receives the tourniquet at least once. But sometimes you apply it twice. Why? Because sometimes you don't see the vein. Or the veins that you see, you're not feeling comfortable with because you think that they are too small. Or maybe it looks like it's a vein, but it's not a vein. Or you don't see the vein at all. You apply the tourniquet, you find the vein. Now that you find the vein, you remove the tourniquet. You do not leave the tourniquet from the moment that you apply it. You clean with the tourniquet over there. You do not do that. Because by the time that you apply the tourniquet, you clean and you prepare your stuff, it has been more than 1 minute. And if the patient has the tourniquet for more than 1 minute, what's going to happen to the blood in those tubes when you put them there? It's going to be hemolyzed. It's not going to be good. So the results are going to be false negative, false positive. The laboratory is going to send you that. It's going to say, listen, call your patient again and draw the blood again. And who likes to come back again for blood to be drawn? We don't have time, number one. Number two, I don't want to be poked again. I might have something else to do. So our job is to do the things right the first time. So we apply the tourniquet. We find the vein. If we don't see it, we don't feel comfortable with the vein. Particularly when you're new, try to do it twice.
Alright, so we cut it.
Find the vein.
Once we find the vein, we
Remove the tourniquet.
Clean.
Now you clean.
Okay.
And after you clean, you come here and prepare your tubes. You assemble your needle, get everything ready. So by the time that this dries, because remember that alcohol, you should not be venting, you should not be blowing, you should not be getting the gauze and patting right there to dry it off. Because what we do sometimes is we prepare everything and we leave the cleaning for last. And then we have to stand right there until it dries. Because if we put the needle right when this is still wet or moist, with alcohol and you put the needle over there, what's going to happen?
You're gonna have to.
There are
the-
two things.
The chemical of the.
First of all, that's going to burn the patient. The patient is going to move. The patient is, oh, no, remove the needle. Something is going on. That's number one. Number two, the alcohol is going to contaminate the blood. So some of the results that you might need, not necessarily alcohol levels, are going to be false positive, false negative. So am I be receiving results from my patient that didn't have anything, but now because of you, thank you very much, now they're going to have to reevaluate me again, or probably start me with other medications or send me for another test that is not necessary. Is that understood? Remember that now we have problems with those insurance companies that they don't pay for certain amount of tests that you order. You have certain amount of tests that you can get in a period of 6 months. And you cannot go above, no, you cannot go beyond that. So now you are in a critical condition, but you did the test wrong. Now this patient doesn't qualify, the insurance is not going to pay, and the patient doesn't have money because even though if they don't want to pay because they have insurance, right? They come up to you. So let's do the things right. Always do the things the best of your knowledge, because that's going to save you some time. And if this happens once, twice with your patient, the doctor is going to kick you goodbye. This is like you're getting in trouble. Having patients all the time complaining about the same laboratory sending me, then you have to call the patient again. And remember, you don't call the patient. Who calls the patient? Well, let me rephrase it. Let's say that the laboratory call you and said, listen, you have to call the patient to draw the blood again. What are you going to do? You have to tell the doctor, and the doctor is going to authorize you to do it. You can't just call it up on yourself, said, oh my God, I make a mistake. I'm going to call it, and you can say, oh, please come, listen, I take care of you. The first one that comes, I know all this drama. No, the doctor needs to know that the results are not there, that the results were refused, that were rejected the blood, and that you have to call the patient again. All this has to pass through the doctor. You do not call the patient and draw blood again and send those bloods to the laboratory. You don't do that. You definitely get fired. That's a violation of the code of ethics right there. So be careful. So that's basically what you do. It's very important that you follow all your protocols in your office, because if you don't do it, you always can get in trouble. Okay, so needles, we talk about the tourniquets, right? If you apply the tourniquet too tightly, what's going to happen?
Stop the blood flow.
That's one. And the patient is going to feel like numb, the hand, tingling, and becomes pale, numb. But what's going to happen to the blood?
You're gonna get hematoma. How you say that?
No. The blood is going to be hemolyzed again. The blood, you know, the red blood cells, white blood cells, and platelets, they're going to burst open. They're not good. Not good at all. But what's happening to the patient? The patient is going to develop something that is called petechia. You heard that? A little dots, like red dots. When you apply too much, it is too tightly. Then underneath the tourniquet, you're going to see all these little pinpoint little dots, red dots. That's called petechia, because you broke all the little capillaries around because it's too tightly.
So I got in birth control, right? And then the doctor, she put like a band-aid, right? Real tight. And it caused me to like burn. After happened to it caused me burns, and I have like water coming out.
Oh yeah? Like a little, like blisters?
Blisters.
Oh.
She put it aside. I could have sued her for that, right?
No, you cannot.
Too late now.
I'm not gonna tell you you can sue. No.
No, I'm just saying. No, but that did happen.
Yeah, to dry. You didn't know that one? Come on. You got all of them right.
30 seconds.
30 to 60 seconds. 30 to 60 seconds. Remember, the tourniquet has to be there for 1 minute, no more than 1 minute. If it is more than 1 minute, then remember, you're gonna develop another problem with the blood. Hemoconcentration. Too many blood because you are kind of stopping the blood. So they pulse, and all these blood, extra red blood cells is gonna go into the tube, and you're gonna be seeing too many. It's gonna be rejected by the laboratory. Remember that when the person in the laboratory analyzes them, they know. You cannot see by just looking at the blood, oh, it's hemolyzed. You can't tell. It's when you process it that you're going to see the results. So that's basically what it is. So how far from the site of the injection or the needle you're supposed to be placing the tourniquet? 3 to 4 inches. 3 to 4 inches, always. If it is in the hand, right here, 3 to 4 inches. If it is on the antecubital fossa, 3 to 4 inches. So for you, what I want you to do is, only for exam questions, remember those numbers. 3 to 4 inches above. Read all the questions, because sometimes it says 3 to 4 inches below. Right here, if it is on the upper arm, usually use the middle of the upper arm. See, the middle. Don't go there measuring, putting fingers, something like that. The less you touch the patient, the better. Remember, you have to go there like a pro. Pretend that you know a lot, that you know what you're doing. Even though if you're shaking inside. Is that understood? You know where you put your tourniquet? Right in the middle. If you put it too low, it's gonna be right there with the knob and all these tourniquet is gonna be there, and you're gonna be pushing it, moving it back and forth. Uncomfortable. Leave it right there. So it's the best thing that I can tell you. But for text purposes, remember, 3 to 4 inches above. That's very important, because definitely you're gonna have it. You put the tourniquet because you didn't see the vein. You find the vein. You clean the area. You guys learn how to clean correctly. That I give you that. I saw the videos. All of you have the same techniques. But with the tourniquet, you left the tourniquet in place. From the moment that you place it, then you clean, then you get everything done, and the tourniquet still was there. No. Remove the tourniquet, clean, and you reapply the tourniquet. When you're ready, when you assemble the needle and you have your tubes, you have your gauze, you have your Band-Aid, you have everything with you, next to you. Remember the sharps container. You must have a sharps container right next to you. Never recap a needle. Those needles that you already withdraw from the patient's vein, you do not put the little cap cover back again. Never. Because that's the time that you're gonna miss it. You're not gonna go through that little cover, and you're gonna pop your fingers. You don't know what the patient has. If the patient has any condition, an infection, a sexually transmitted infection, it's gonna pass to you. The most common ones, which ones are the most common ones? Infectious diseases that you can receive from a patient. The most common ones. HIV and what else? No.
Tuberculosis.
No. No.
Hepatitis.
There you go. Hepatitis B.
Ain't that herpes?
Have you read it? She was like,
No.
I don't read no lips. Say it loud next time. I thought you said herpes.
I said herpes.
What about C?
Hepatitis C? No.
Which one? What is the thing for herpes? Isn't there like another?
There are different type of herpes. Herpes simple, 1, 2, and herpes zoster.
Don't all of us got simple?
No. Simple is the one that you develop in your lips.
Like, don't everybody get cold sores?
That cold sores are number 1. Herpes simple, number 1. Number 2, that is the sexually transmitted herpes. And the one that you develop when your immune system becomes weak and you have chickenpox when you were a child, that's called herpes zoster or shingles for most commonly called. So once again, you're gonna be asked, if you get stuck with the needle from a patient, what are the probabilities of getting which of the following infection? Look for hepatitis B. Hepatitis B is like 3% chances that you get hepatitis. HIV, it is 0.3% that you will get it. Yeah, it's a lot more difficult. No, it's hepatitis B, very easily you can get it.
And then the dangerous part about HIV is you can text for it and then it won't pop up and then
Yeah, it could be
5 years.
Oh no, you have to go to treatment and do all those things for months.
I would like to ask a question. So, God forbid if that happened to somebody
Mhm.
and the patient just had herpes. Because I know, had HIV because I used to work in a shelter. So, somebody got spit on while crying and they had to take something called a cocktail, like different medications
course.
that happened.
Yeah.
Oh, so that is
Yeah.
fine.
Anyone who gets, anyone who gets in a needle stick, let's put it this way, little stick, even though if I don't know what is the status, your medical status, because remember, one of the things that you have to understand, patient's privacy and confidentiality. If you get into any accident or incident with the needle with the patient, you cannot ask the patient, oh, hey, do you have HIV? Do you have this? No, you cannot ask that. That's a violation. This person can sue you.
Yeah.
You have to talk to the doctor, and the doctor who is the doctor of this patient, if the patient is aware of that, sometimes the doctor tell you, because we work together, says, be careful when you draw blood from this patient. We have certain population that we are going to be very careful with them. We are protecting our staff.
Right.
We don't want any issues to happen. At least to make you aware that, you are in a very dangerous zone. But regardless, because some patients, we don't know what they have. They don't even know what they
I was
have.
about to say, some of them don't know what they
Exactly. So then, how do you know? So the most important thing is to be focused on what you're doing all the time and not to distract yourself with needles. Always on the lookout.
But the butterfly needle pull in, right? The butterfly needle pulls in.
Well, those are the safety devices of the needles. Some of them, you can just press a little button and the needle goes in. No, it's not. It's excellent. But you know how much costs just one little needle? $3.50. So whose doctor is gonna ask?
Yeah, right.
So we use the one that costs like $1.52. You know how much costs one of these needles? Why what?
$5?
Nah.
$1.
This costs like 50 cents.
Oh, for real?
Yes. How much this one? $2 and $2.50.
So if they cheat,
So
people have
of
to-
course,
They're gonna
if
be
you're gonna go to
cheap, yeah.
certain, that's the idea.
Yeah.
If you have business, what do you want me to use? This one or this one?
This
Well,
one.
this one I can buy 20 of this
Right.
versus one of this. So, but for the safety reasons, since I've been using this since 2005, and when I started using this, I never went back. Like Kamala Harris. We're not going back. So, for my safety, I feel very comfortable doing this. And my patient, if you compare these two needles, it is so small. If you look at this, it's very long. It's like double the size. So as soon as you see it, said, "Oh my God,
It's
is
a
that
little
one?"
scary.
Yeah,
See it
is that
coming
one
from
anymore?
the
No. So, anyways, it's better to spend a little more money for your safety, for your safety, and it's easier because you know when you hit the vein, you know when the blood is there. Instead of fishing with this, because if you don't have the blood, how do you know? You have to put the tube first. And then if there's no blood there, moving the needle back and forth. These ones you don't have to do much manual work. So those are very important things that you need to know. Remember, which gauge are you going to use on the hand, on the dorsal part of the hand? 23. Always think that the largest one is the smallest one.
So
Always.
23 could be used on the foot for the baby.
No, we
Yeah.
don't do that. No,
That's
we
why
have a
it's too
lancet.
big.
It's a different.
What's the different one?
That is, yeah, that's dermal puncture.
Well,
That's
then I work with pediatrics.
you wanna work with pediatrics? That make two of us. I don't like to work with the pediatrics. Not because of the little kids. I love them.
Just the
The
parents.
family.
Yeah.
My goodness. Can you imagine having their
12 years old, step forward,
having their parent who is very demanding, and if they don't care about the neighbor, the other patient that is dying? No, my patient, my son, my daughter is first, and they tell you what to do. Oh no, don't touch it like this. Oh wait, oh give it a minute. Listen, I have no time here to be, and they are.
Don't start crying with those kids. Don't start crying with them.
I was a little aggressive. They used to bring my
You're
baby
crying,
back crying. And I just want-
I
be
don't
sleeping,
cry.
my baby
I'm
back
punching, moving my face everywhere. Yeah, particularly, mostly the mothers. The fathers are more calm. But the mothers, oh my God, they demand every single thing. Because you're the mother, you're the one who have it, right? And you don't want any harm to your child. But sometimes you interfere whatever we're doing. So that's not good. So when I see a mother that is a little too much, I ask security. Security! Yeah? And they bring them like this. No, just kidding. No. Okay, so that's what it's all about. What time is it right now? Oh my